Okay, let's talk about a SOAP note. A SOAP note is something that we use as a format for medical documentation. S, O, A, and P. S is for subjective, O is objective, A is assessment, and P is plan. S, subjective, that is all the information that the patient tells us or is in their history. So this includes things about what's going on with the current complaint that the patient might have. It includes past medical history, surgical history, medications that the patient has been taking, etc. And we'll walk through that in detail. It can also be from other sources than just the patient. It could be a caregiver, it could be a family member, it could be another physician, it could be even a medical chart that you review. It's all the history of the patient, including anything that is currently occurring with the patient. O is objective. That is the exam. That's the stuff that we see on viewing the patient. It's the things that we hear when we listen to the patient's heart, lungs, abdomen, etc. It can also include lab work and x-rays that we review, and we see either the report of or we see the actual images, and that's going to be included in that as well. When we look at assessment, that is our diagnosis, our list of diagnoses, or even a list of differential diagnoses that we need to consider. P is plan. It can be either what we're going to do for the patient to treat them for the diagnosis, or it could be further workup such as radiology and lab work, or even consultations with another physician that we need to get more information to or be able to manage the patient. So let's walk through this. S is a subjective portion, and that's going to be the things, again, that the patient's telling us or that we have in their history. So in this case, we have Mr. Smith, a 45-year-old man who presents to the family medicine clinic complaining of left-sided chest pain, which started about 4 hours ago. There are a number of things that I'd like to ask this patient, and I need to ask this patient in order to gather enough information to have a good fill of and a good list of differential diagnoses that could be occurring with this patient. How do we do that? There's a mnemonic that we use, which is OLDCARTS. 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 What does that mean? So O is onset. When did this start? L is location. Where is this? D is duration. And duration is not necessarily the same as onset because it could be that the pain comes and goes. There's times when it starts and times when it stops over a certain amount of time. So the onset could be 4 hours ago, but the duration of the current pain could be 15 minutes. Or the duration when it started 4 hours ago could have been for 10 or 15 minutes and it subsided. So not necessarily the same as onset. C is characterization or character. What type of pain is this? Is it sharp, dull, achy, pressure, those types of things? A stands for aggravating and associated symptoms. What makes this worse? What aggravates it? Does rest make it worse? Does activity make it worse? Does a certain medication make it worse? An associated symptom is anything that occurs in addition to the chief complaint, as we call it. In this case, chest pain is their chief complaint, but what else is occurring at the same time? R is relieving and radiation. What makes it better? Does rest make it better? Does taking an aspirin make it better? Does taking a nitroglycerin make it better, etc.? And does it radiate anywhere? Does the pain go anywhere else, or does it stay on the left side of the chest? Certainly that's important depending on the situation. T is timing. Does it occur a certain time of the day? Does it get better or worse at morning or nighttime? Midday. S is severity. On a scale from 1 to 10, for instance, how severe is the pain? So let's go through this patient's history and see what we can find in terms of what is occurring with the OLDCARTS. And we consider this parts of the HPI or history of present illness, the history of the current chief complaint. So we have left-sided chest pain. We have location. We have 4 hours ago's onset. He states he was pushing his yard when it started. We also know, and it's nice to know, what was occurring at the time of onset. Was he pushing his mower? Was he laying on the couch? Was he lifting heavy furniture? The pain is described as a pressure-like sensation. Pressure-like. We have characterization. And that's certainly important because pressure-like pain, especially with activity, really makes you consider cardiac as the possibility for this chest pain, especially since it's on the left side of the chest. It was an 8 out of 10 when it started, and it's now a 7 out of 10. It's nice to know what was it like on a scale from 1 to 10 when it occurred, and is that worse or better now? So this patient had an 8 out of 10. It's slightly better at 7 out of 10 now, but that's still pretty significant. But we know the severity, which is very helpful. This is a pretty significant chest pain. He states the pain radiates to his left arm and is associated with nausea, diaphoresis, and shortness of breath. Those are certainly key things to know. So we've got our radiation part of the R. We have our associated symptoms, and these are important because if it's cardiac chest pain, things that you might see as pressure-like sensation that's pretty severe with activity, and it might radiate to the left arm, and it might have nausea, diaphoresis, or sweating, and shortness of breath associated with it as well. Okay, let's get into the past medical history and other parts of this patient's history. All right. So, past medical history includes hypertension and hyperlipidemia. Those are certainly risk factors for cardiac disease. So, again, we have to really think this patient could be having a cardiac event, an acute MI or myocardial infarction. Past surgical history, he denies any surgeries. Medications, he takes lisinopril 20 milligrams daily and simvastatin 40 milligrams daily. Again, medication for his medical problems, his hypertension and hyperlipidemia. Family history, his father was deceased at age 48 from an MI. Mother alive and with hypertension and no siblings. So this is important, right? It's important to know if a parent or any first degree relative, such as a sibling, which he doesn't have, had what age they died at and what they died from. His father just died at 48 from an MI, and this patient is 45, presenting with typical chest pain, meaning this sounds a lot like cardiac chest pain. So without doing an exam, running any tests, we already have a good idea of what could be occurring with the patient. Could this be something else? Absolutely. But does this sound like an acute MI? Absolutely. Social history. This patient also smokes 2 packs of cigarettes per day. Why is that important? That's certainly a cardiac risk factor. It's also damaging the lungs, and certainly respiratory issues could also be something that's causing this chest pain, but certainly a cardiac risk factor. He drinks 3 to 4 beers on the weekend, so not heavy alcohol. He denies any illicit drug use, and he works as an office manager. Why is an occupation important? Why is that there? Well, if he works as an office manager, he's probably not getting a lot of activity throughout the day. So he has a sedentary lifestyle in terms of work, and when he was outside push mowing his yard, he was getting pressure-like left-sided chest pain that radiated to his left arm with nausea, diaphoresis, shortness of breath, and it was an 8 out of 10. That's pretty significant and important. Okay? Allergies. Why do we want to know allergies? If I'm going to give this patient or consider giving this patient a medication, I need to know if they've ever had a reaction to it. So in this case, he's allergic to penicillin. It causes rash and shortness of breath. Sounds like an anaphylactic reaction, and that's certainly a true allergy. Patients will commonly have a lot of adverse reactions to medications they list under allergies, partly because there's no other good place to list it, but also patients can sometimes mistakenly think that it's an allergic reaction, such as it upsets my stomach, or it caused an itchy feeling one time, those types of things. So it's important to know what the reaction is, because if it's a medication that I really truly need to use in this patient, and I don't know that it was a really simple adverse reaction rather than an allergy, and just call it an allergy, I might not use the medication when I should. And he has no seasonal allergies. So another part of the history or subjective portion is review of systems. And review of systems is important because it looks at other things than what the patient is complaining of. And so what do they have GI related? What do have GU related? What do they have respiratory related? And this patient did have some shortness of breath, but we might dive into that more and ask about cough. And if it's a cough, was it productive of sputum? We might ask neurological questions. We might ask a number of other questions in different systems of the body. Why is that important? Because sometimes you pick up on things that you wouldn't have otherwise because the patient was so focused on what's currently causing them issues. You might pick up on something that's vital, and it might even be something that could be related that you wouldn't have picked up on otherwise. So it's nice to do at least some review of systems as you discuss things with the patient. And those are typically things that we consider to have happened in the past 3 to 6 months. So if it happened a few years ago, it's going to be less important, at least for the current situation. But if it happened more recently, it might be important. It might be something I need to investigate. O is objective. That's the stuff I see. That's going to include the vital signs, which gives me some important information. What do I think is going on subjectively with this patient? What does the history tell me? I got to certainly think about an acute MI. Let's look at his vital signs. Does he have a fever? No. So infectious causes certainly are a little bit lower on my list without a fever. Doesn't mean they're eliminated, but they're lower on the list. He's satting 94% on room air. So his oxygen level is low. Not terribly low, but not normal. Respiration rates are 20. So it's within normal range, which is 12 to 20. His pulse is 95. So it's up a little bit, but not above 100, where we call it tachycardia. His blood pressure is up as well, 158 over 95. So the question is, if his blood pressure and heart rate is up, is that due to pain and he's in distress, or is that perhaps his blood pressure has not been treated quite as well as it should, or there's a physiological issue occurring in the body currently that's causing his blood pressure to be higher? And that could be that he needs to get oxygen places and his body is raising his blood pressure. General exam is always nice to include in this. How does he appear when you look at him? So this patient's in moderate distress and he's holding his chest, slightly pale in color. That's super important because, again, how severe is this pain? What do I think is occurring? If he's in moderate distress, holding his chest, and he's pale in color, I got to take this as pretty serious. Cardiac exam, cardiovascular, regulating rhythm, no murmurs, rubs, gallops, radial pulses equal and 2+ bilaterally, no carotid bruits. So listening to him with a stethoscope and palpating his pulses seems to be okay. Respiratory wise, it's clear to auscultation bilaterally, no wheezes, rhonchi, or crackles. Extremities, no clubbing, cyanosis, or edema. All right, so obviously, acute MI is one of those things that I said was already on my list, but looking at this patient's history and his exam, what are the things that we are going to consider? And why? Why was this subjective so important to get? Because we gained a lot of information. We gained risk factors, including family history, social history, including his occupation that's putting him potentially at risk of cardiac disease, as well as his smoking. We also gained his past medical history, which are risk factors for cardiac disease. The exam shows an elevated blood pressure, elevated heart rate, though not truly tachycardia, slightly low oxygen level, and more importantly, he's in moderate distress, holding his chest, and he's pale in color. So this guy is sick. Acute MI would have to be one of the things that I would put under my assessment. What do I think is occurring? I think it's an acute MI. But I have to consider other possibilities. It could be unstable angina. That's not truly a myocardial infarction, which is still very important. It could be stable angina. Pulmonary embolus, and again, I think this is unlikely in this case. There is no history given, at least, of this patient having a red swollen leg prior to this. No past medical history of blood clotting or thrombus in the past. So pulmonary embolus is going to certainly be lower on my list. Pneumonia, I doubt it. Again, he has no fever. His lung exam was totally unremarkable, and he doesn't really complain of any respiratory issues except for some shortness of breath when the chest pain occurred. So pneumonia is still going to be on there because it's in the chest, but it is not likely. What do I want to do with this patient plan-wise? So my subjective gave me a lot of idea of what could be occurring. My exam gave me some more information, especially how he generally appeared, leading me to my acute MI as a high likelihood, and then the unstable and stable anginas being after that. So what do I need to do for this patient? I'm going to get an EKG, and I'm going to see what the EKG looks like. Does he have an ST elevation? Does he have Q waves? Does he have other abnormalities that I need to worry about? It could be an arrhythmia of some other sort. If I'm seeing this patient in the clinic, I'm going to get 911 so I can get an ambulance dispatched. I need EMS to come get this patient and take him to the ER. What can I do for this patient otherwise while I wait for EMS? I can give him aspirin, because according to his medication list, he is not taking a daily aspirin. He's just taking his antihypertensive and hyperlipidemic medication. I can give him some sublingual nitroglycerin to try to help ease the pain now as well, because he still has a 7 out of 10 pain. It's still occurring. It's still pretty significant. He looks like he's in distress. I need to help get that pain resolved. So sublingual nitro to open up his coronary artery so he can have some more oxygen perfusion, decrease his pain. I can also give him some oxygen because first off, his oxygen level is on the low side. Secondly, if he is having a MI, I need to do everything I can to get oxygen in his system and try to get oxygen to his cardiac tissue. So looking through this, again, that's subjective. The history of the patient gives me a lot of information that leads me in a direction. The objective is either going to refute or push me away from what I'm thinking from the subjective, or it's going to help add to the possibility that what my initial thought or diagnosis or list of differential diagnoses is, and in my assessment and my plan is going to tell me what I need to really think about and what I need to do about it. So hopefully this really helps in terms of thinking through a SOAP note. And again, if you follow this format every time, it should be very, very helpful in figuring out what is occurring with the patient. The HPI mnemonic Oldkarts is extremely helpful in remembering what you need to ask. When did it start? Where is it? What's been the duration of it? Has it come and gone, or has it been the whole time? Characterization, what kind of pain is it? A is the aggravating, what's making it worse, and also the associated symptoms. R is radiation as well as relieving factors. T is timing. Is there a certain time of the day that this gets better or worse? And S is your severity. While we didn't answer all the Oldkarts in this patient subjective section in the HPI or history of present illness, we got a number of those items which gave us a lot of information of what could be occurring with the patient.